Thank you. I really appreciate the invite, Belinda, and thanks for all the participants. And I think, as I say, patients probably know better than the physician about any rare disease. So I learn a lot from patients and their family about their disease more than what I learned from physician. And I'm happy to share my perspective from the kidney standpoint. So I'm gonna start. Let me just go here. My name is Mohamed Atta, and as Brenda mentioned, I'm a nephrologist at the Johns Hopkins Hospital in Baltimore. Talking about the kidney with ECD, we're just gonna look at the kidney involvement in ECD and look what actually predict the kidney outcome, so kidney disease progression and kidney failure in those patients, and how to manage those patients. So I'm going to start with an image because I think from most of you, you have seen, you have had a lot of images during your journey with ECD, and this is a CT, and this is really from the web. It's not my own CT, and it's not taken at Hopkins. It's just uh, uh, I'm gonna take the pen here so I can point to where we are. So if you take a CT and like the patient is standing, you can see that this is the aorta, and the aorta has a renal artery that goes to the kidney, and this is your kidney bean-like structure right here. So you have two kidneys, the right kidney and the left kidney, and then there's this tiny thing coming out of the kidney, which is a ureter, which goes eventually to the bladder right here down here. And the same for the left kidney. You have a ureter that goes all the way. You don't see it obviously clearly, but it ends up in the bladder. That's how the urine comes out. And this is your big liver right there. And this is the inferior vena cava, which is a big vein next to the aorta right here. And if you take the same picture, but you do it as a cross section, so you cut the images cross sectionally, you can still see the kidney right here. This is the left kidney, and this is the right kidney. And again, the IVC, since you are cutting it cross sectional, you will see it as a round structure. And this is the aorta, again, a round structure, and the duodenum and the jejunum. These are the intestine. So again, just to give you an idea what we look for when we make a diagnosis of any kidney disease. So why are we talking about the kidney? Well, the kidney is involved in many systemic disorders, and we are interested obviously in ECD, but the kidney is the host for a significant number of systemic disorders. Some of these are genetic disorder like tuberous sclerosis, von Hippel-Lindau disease. You may have heard of autosomal polycystic kidney disease, which the kidney becomes totally cystic. This can be autosomal dominant in adults or autosomal recessive in kids. You have also these group of disease, which is what we call deposits disease, meaning that there's abnormal protein deposits in the kidney called amyloid, which is the same deposit that happen in Alzheimer's disease. It's amyloid in the brain. It can actually have a different amyloid type in the kidney as well. You can have calcium phosphorus deposit in the kidney. We call it medullary nephrocalcinosis. We can have iron deposits in the kidney. We call it kidney or renal hemosiderosis. And then you have this group of disorders that we call inflammation or infection of the kidney. It can be tuberculosis. It can be IgG4 related disease as well. But then there are these neoplastic disorders, and a lot of them, we have lymphoma, we have leukemia. All of this can go to the kidney. And obviously, we are focused on histiocyte-related disorders, which are Erdheim-Chester disease and Rosai-Dorfman disease. You can see from this slide that it's actually, those are rare conditions in general, because the most common systemic disease of the kidney is diabetes in the United States and the Western world. So diabetes is number one cause of systemic disease and kidney disease in the same time. So not included on this slide, these probably much rare compared to diabetes disease. So the first question we usually ask, what is ECD? And Erdheim-Chester, and I know that you probably heard a lot of webinar about Erdheim-Chester, and it is a histiocytosis disease, and histiocytes are basically originates from the white blood cells. So we usually divide histiocytosis into Langerhans and non-Langerhans. And the reason for this division is really driven by Dr. Paul Langerhans, which is a pathologist, a German pathologist, who described the first one to describe Langerhans cells or histiocytosis. And what he described was these immune cells, we call it dendritic cells, in the skin. And we thought that these Langerhans cells are the home, or the skin is the home for these histiocytes. But it turns out that histiocytes are found elsewhere, but we call it non-Langerhans because the origin of that cells is not from the dendritic cells, but it's from the phagocytes. And it could be obviously confusing. What about Langerhans versus non-Langerhans? So think of it as a factory that has the same product, and one product has this marker, it's coming from the same factory, but there are two different products. One that we call it, and the markers are CD1. This is really a marker on the cell that is positive in Langerhans cells, are negative in non-Langerhans cells. So the main difference between Langerhans and non-Langerhans are the positivity of this marker on if you do histology. But before we have the immunohistochemistry and doing that, we had to look under the microscope. And the feature, or the pathogenic feature of Langerhans cells, are these granules. We call it Birbeck granules, and I'm going to show you how it looks like under the microscope. This is electron microscope of these Birbeck granules, and you can see it has this zipper like rod with a bulb at the end, and think of it as a tennis racket. So once you see this on tissue, this is a Langerhans cell. And since it was first described, as I said, by Dr. Paul Langerhans, it carries his name, Langerhans cells. And because he described those in the skin, you can tell that the majority of Langerhans histiocytosis are involving the skin, and also the population involved are usually children. So these are Langerhans cells, and I don't treat those patients. I don't generally see them. They are seen by pediatric oncologists, hematology folks. I deal with the non-Langerhans cells, which don't have these Birbeck granules. So this is really the feature that discriminate between Langerhans and non-Langerhans cells, in addition to the CD18. All the histiocytes have a marker. We call it CD68. So we test for that to make sure that these are histiocytes by CD68 marker. So each cell has what we call a feature, or what I call a whisker. If you think of a whisker on outside the cell that actually identify which cell it is. So CD68 is the whisker for histiocytes, and then CD18 that actually only present for Langerhans cells. Again, Skin involvement is common in Langerhans cells, and non-Langerhans cells, skin involvement is uncommon. It's usually systemic disease. And that's where Erdheim-Chester comes from, non-Langerhans cells. So, having said that, the ECD is a non-Langerhans cell histiocytosis characterized by these foamy cells that are positive for CD68 and negative for CD1A. So to differentiate them from the non-Langerhans cells, it is multi-system infiltration of these histiocytes of the bone, retroperitoneum, which involve the kidney, obviously, cardiovascular disease, CNS, lung. The bone is very common, as you may have heard in the past, that Erdheim-Chester affects the bone in the majority of patients. Although, I mean, the majority of my patients don't have bone involvement. The diagnosis for these disorders need tissue. Tissue is usually the issue. We cannot really make a diagnosis without tissue. So despite the fact that imaging is very characteristic for kidney involvement, but we like to have the tissue, and the tissue is important for the treatment, as we will tell in the coming slides. So I like history, and I go back to Dr. William Chester, and you can see that a lot of these rare disorders are actually discovered by pathologists. So Dr. William Chester was a pathologist from New York, and he is credited for the first description of Erdheim-Chester, and he called it, this is in German, and I don't read German, it's called lipoid granulomatosis, which is the old name for ECD. And Uber is about, it's not our Uber taxi. It is this is about lipoid granulomatosis. And he is the first person to describe these lipoid granulomatosis. And he did work with Dr. Erdheim. And Erdheim was another pathologist, but was in Vienna, and he was the director of this municipal hospital in Vienna, Austria. And he went to Austria and he started to look at those cases. And he had, as I said, described these lipoid granulomatosis. And this was the first classification of lipid-laden histiocytic disorders. And he showed that it actually involved the bone, the osteosclerosis, which is fibrosis of the bone, and also the lung, the heart, the kidney, retroperitoneal fibrosis, and also the eyelids. And if you look at Dr. Jacob Erdheim, who was as I said, this is him. In Vienna, in this municipal hospital. He was not actually involved at all in Erdheim-Chester disease. He was more involved in brain pathology. And you can see him here with brain on his plate. And this pathologist was very reclusive. He lived actually in the hospital. He has a room in the hospital. He was not married. And he had a couple of episodes of infection, one with tuberculosis and one with typhoid. He was hospitalized for both, but he concealed his infection from his colleague and his students. And he died mysteriously at age 67, but people think that he died of unrecognized cardiac disease. So he carried, since Dr. Chester was visiting him in Vienna, he eventually, when he published his paper about Erdheim-Chester, which he called lipoid granulomatosis, he basically had his boss or his mentor, Dr. Jacob Erdheim, on the paper, and that's why we call it now Erdheim-Chester, just to make the two pathologists are the one that discovered the disease. So how actually Erdheim-Chester happened? And this is, again, maybe a repetitious for some of you. we know that the majority of cases are related to this active mutation in this BRAF gene, and the BRAF is a gene on chromosome 7, and BRAF gene encode for this protein that we call BRAF, carries the same name, and BRAF protein is responsible for cell division and cell growth. So imagine if you have active mutation, meaning that this protein is working over and over and over again, it actually activates the cell division. So, and the mutation happen, as you know, that you uh, inherit 6 billion letters from your mother and your father. So each cell has those 6 billion letters, and 3 billion from your mom, 3 billion from your dad. And those letters have to be copied with each cell division. And when you copy 6 billion letters, you can make mistakes. And the more you divide, the more likely you make mistakes. And as you can tell that since the most dividing cells in the body are blood, skin, and the intestine, and you can tell that the majority of cancers happen in the skin and the blood and the intestine, because those are the cells that divide more often than any other cell in the body. And those are the more likely to make mistakes because you are copying, each division has to copy 6 billion letters every time. And for instance, your skin replace all the cells are replaced in 7 days. I mean, this is really you have to get rid of all the old cells and get new ones. And so I say that really mutation happen because of more divisions in the cell, more likely to make mistakes. And what actually trigger the mistake is more division, but sometimes it's viral infection, sometimes it's environmental. It's bad luck. So most cancers are bad luck, basically. Uh, so when you have this active BRAF or active mutation, you have these growth and more division of these histiocytes that will invade organs, and some of these organs obviously is the kidney. And you can see here that more than 60% of patients with Erdheim-Chester will have this activating mutation, where the amino acid 600, number 600 of this protein, the valine, which is amino acid, is replaced by another amino acid called glutamic acid. So that's at the position 600. But you can see that the rest of cases are, some of them are unknown, but there are other mutations. The most common one of these mutation is called MAP kinase class 2, and these are also make the cell divide more and also grow more. But the majority obviously are BRAF mutations. So how the kidney is involved, and the problem with these type of disease that most of these presentation are asymptomatic and discovered accidentally. Sometimes patients will have flank pain, pain in the back. Sometimes they have been discovered by abnormal kidney function that they get imaging. And so the majority of patients are often asymptomatic, and there is a delay in diagnosis, not just because they are asymptomatic, because a lot of physicians don't know about the disease as well. As you know, this is a very rare disease, and we're talking about 1,000 cases worldwide. Uh, but this is the retroperitoneal infiltration happen in about 60 to 70% of Erdheim-Chester patients. So the kidney is really at the center of this disease. And it's usually the perirenal, meaning that the kidney is engulfed with this infiltrative histiocytes that makes it hairy, and it has this characteristic feature on the CT that I actually published this on one of my patients. And you can see, you remember the CT that I showed you. And I remember this patient particularly because this patient was sent to me for retroperitoneal fibrosis. And he was having this blockage and kidney problem. And you can see here that the right kidney was dilated a little bit. And but when I saw his picture, since I have been treating Erdheim-Chester, I told him, you have Erdheim-Chester before even diagnosing him by tissue, because as I said, you have to make a biopsy for every patient. So you can see here that this patient had this coat, which is obviously the kidney in this cold weather, maybe in east in Baltimore now with all the snow. It has this coat around the kidney, and this coat looks hairy. And these are all histiocytes infiltrating the kidney, the outside of the kidney. So, and then when we biopsied the patient, you can see these foamy cells on the light microscope. But as I said, to make sure it's histiocyte, we look at the marker, which is CD68, and you can see these brown cells are actually histiocytes because it is positive for CD68. So that's how we make the diagnosis for these patients. Now, the largest cohort of Erdheim-Chester comes from Europe by Dr. Harouche from France, who did a lot of work on actually on Erdheim-Chester, and Dr. Vallo from Italy. They have described the majority of kidney involvement in patients with Erdheim-Chester. And this is really a 20-year type of study, like looking from 2000 to 2020. And they have 195 patients, 147 were involved with the kidney. And you can see the perirenal, meaning around the kidney, is you can see 73% of patients have actually perirenal involvement, and 27% don't have perirenal involvement. And here is the pictures, and you barely see the kidney because it's engulfed by this tissue around it. And but also he had periurethral. You remember the urethra that comes out of the kidney, and it's bilateral for the majority of patients. So perirenal around the kidney, and then around the ureter, and both ureters are usually involved. And you can see that this kidney is obstructed because the ureter is not draining, and this black stuff is basically urine that is not draining from the left kidney. And this is the right kidney, again dilated here, but you can have unilateral involvement as well. And this is followed by hydronephrosis. Hydronephrosis is a result of obstruction. Hydronephrosis means that the kidneys are not draining. So you can have periurethral involvement, but no obstruction. But you can have periurethral involvement, and then you have blockage of drainage as well. So this is your ureter coming from this right kidney, and this is from the from the left kidney. And you can see that this is the hair or the perinephric involvement as well. And then you can have kidney atrophy in about 8% of cases. Kidney atrophy tells me that those patients were discovered very late in their disease process, and the kidney here is really small because it has been damaged by the infiltrative histiocytes. You can have adrenal involvement in about 14 to 19% of cases. You can have 14%. The adrenal gland is, both adrenal glands will be involved, and 5% will have only one adrenal gland involvement. And then you have vascular involvement, meaning the renal artery, which can lead to blockage of the renal artery. So we call it renal artery stenosis. And this happened in about 30% of cases, that the vascular tree of the kidney is involved. And when Harouche looked at those patients, he compared the patients who had perirenal involvement with no perirenal involvement. And he looked at 142 out of the 195. So 142 patients had perirenal involvement around the kidney, and this is no involvement. You can see here that the majority of patients with perirenal involvement are men, and they are older, 54 versus 46. They have hypertension, 49% versus 23%. They have coronary artery disease, 31% versus 6%. So it tells you that they are older, they are sicker. There is involvement of the heart in the majority of patients, 58 to 28% involvement by Erdheim-Chester. Large vessels are involved also in 71%, and the BRAF mutation is more common in those patients with perirenal involvement, like 67% versus 45%. And as you would expect, those patients with perirenal involvement have more kidney disease, meaning that the kidney function is lower. We call it GFR, or glomerular filtration rate, which is a reflection of kidney function, is less than 60% or 60 ml per minute. So if you start with 100% kidney function, those patients with perirenal involvement have more decline in their kidney function, 32% versus 8%. If you look at what actually predict or what happened to those patients over time in terms of kidney survival, and also what happened to the GFR over time, you can see that here no perirenal involvement. This is here on the y-axis is the kidney function, so from 120 down to 40 here. And then on the x-axis, this is time in years. So as you would expect, and we saw that the kidney function is actually declining over time in those patients who have perirenal involvement compared to those without perirenal involvement. And if you look at what happened to them over time in terms of renal survival, the proportion of patients actually who have normal kidney function at 5 years, 60 months, 5 years. So you will see that by 5 years, about 20% of patients with perirenal involvement lost their kidney, meaning that they are in the stage kidney disease. And this is compared to about 10% of patients without perirenal involvement. So what predict actually the declining kidney function by more than 25% or reaching advanced kidney disease? Again, older folks, more than 50 years old, and any other cardiovascular risk factor will increase the risk for progression by 3.5-fold. And age by itself, like age is a risk factor for everything in life, as you know. And so you will have about 2.2-fold increase in the risk for progression of kidney disease. If you look at mortality, so what actually predicts mortality? Again, age will increase risk for mortality. And this was the only thing actually that is very important. And if patients got treated, that was protective, as you would expect. So patients who got treated had a 70% reduction in mortality. And this was conventional treatment because these were from 2000 to 2020. And obviously the conventional treatment at that time was interferon and was not really all the BRAF inhibitors that we use now or MEK inhibitors that we're using in the last probably 7-8 years. BRAF mutation didn't make a difference, although, again, you have to take this with a grain of salt because some of these patients were not treated with the new agents as well. So what is the treatment of Erdheim-Chester when we see patients with Erdheim-Chester? If you go to the old time before the new agents came to market, the initial evaluation was, as I said, tissue is the issue. You do a biopsy and you do BRAF mutation analysis. And then if ECD is confirmed on tissue, so you have CD68, which will tell you that this patient has histiocytosis, and you don't see the CD1A, which is will differentiate between Langerhans and non-Langerhans, and you confirm that this is ECD. That historic treatment or the first line of treatment was interferon. And we used to use interferon for everything that we don't know how to treat. And you know, interferon is antiviral. We used to use it for hepatitis C infection, and it had a lot of side effects, fever and chills, and really patients felt terrible with interferon alpha. And the uh, concept behind using interferon at that time was interferon inhibit cell division. And that was really the main, it was effective in treating ECD. But again, the side effect profile was really a major issue with this agent. And then if you have progression, and if the patient was BRAF positive, and again, was published in 2014. It was a consideration for clinical trial with a BRAF inhibitor, which obviously showed to be very important in the treatment of these rare disorders. And if it's BRAF negative or intermediate, we used to use a lot of other medications, and anakinra, which is a cytokine inhibitor. This is imatinib, another drug that we used in the past. I don't use it anymore. Cladribine as well was one of the other medication. So history, interferon alpha was really first line of treatment. Now we use targeted therapy because we have the BRAF mutation. As I said, it has those patients with kidney involvement have, the majority of them will have the BRAF activation. And so the BRAF inhibitors, we use, I use basically vemurafenib more than the dabrafenib for the BRAF patients. And then if you actually see a lot of patients don't tolerate the BRAF inhibitors, so I switch them to the MEK inhibitor, which is cobimetinib, which is really a lot of patients do well on it. We have to adjust the dose sometimes. So the one thing about the MEK inhibitor, that it doesn't matter whether you have the BRAF mutation or not. It works in all cases, and really I have a great experience and efficacy with this drug. It's really a lifesaver. You can still use other interventions, but I can tell you that for the majority of patients, BRAF inhibitor and MEK inhibitors have been really very successful. And if you look at any cell, as I said, you have a cell. This is a cell membrane, this is the outer cell, and this is a BRAF pathway, which when you activate it normally, the BRAF will activate the MEK, which is another kinase. These are enzymes, and the enzymes will lead to normal cell growth and proliferation and survival. But if you have basically a BRAF that is working all the time, we call it oncogenic BRAF signaling. This BRAF will continue to stimulate the cell to proliferate and divide, and that's why you get histiocytosis, infiltration of organs. And the idea is you can inhibit BRAF by the BRAF inhibitor, so you inhibit this cascade of events. But if BRAF doesn't work, the one downstream from BRAF is the MEK, or another kinase, and you can inhibit that as well. So this will inhibit or decrease cell proliferation and survival. So how do we treat other issues with the kidney? I mean, giving the drug is not the only thing. Sometimes, as I said, the ureter is involved, so you have to put urethral stent, and sometimes you have to put a nephrostomy tube, which is really so urethral stent, which I don't like much because they cause a lot of fibrosis in the ureter, and eventually it makes the life of the patient miserable because it causes pain and sometimes blood in the urine. And after you remove it, it leaves a scar in the ureter, which is not a good thing. So I prefer, despite the the fact that those tubes are outside. So urethral stent in the ureter from usually patients will undergo cystoscopy and then the stent is placed in the ureter. Uh, the nephrostomy tube is the outside and it's done by a radiologist. And it has a bag. Obviously, you have to drain the urine in a bag, outside bag that you put around your waist. So it's not really something beautiful to show off with, but it's temporary until we clear the disease with or the obstruction. Sometimes we need surgical options. Sometimes you have to move the ureter away from the infiltrative process to make sure that the kidney drains well. And rarely you have to move the kidney itself. So we do auto transplant, meaning that we take that kidney and put it next to the bladder. But the problem is that the histiocytes, kidney is like a magic magnet for the histiocytes. They come back to that kidney again. Uh, uh, Blood pressure control is definitely for everybody, and there are medications to protect the kidney long term that we use in addition to these MEK or BRAF inhibitors. So there are a lot of approved medication that actually preserve kidney function that we use in these patients. And then you have to monitor therapy because a lot of medications have side effects, and we'll discuss this. This is a patient of mine that I saw basically in 2025. So this is like exactly a year ago. So February 20. And so I looked at his images, and it's unfortunate because I looked at his images that goes back to 2016. He was sent to me with retroperitoneal fibrosis, and I looked at images from 2016, and he had Erdheim-Chester at that time. I mean, I look at his kidney and the coat around his kidney, infiltrative disease as well. And this patient probably had one of the aggressive disease. So it's not just the kidney, the liver was involved. You can see here a lot of tissue, infiltrative tissue in the kidney. The lung was involved, his bone was involved. And this is, I saw him 220, I did a PET scan 225. And he had a lot of, but this is probably the only patient of mine that has bone involvement that I saw. So, less than a month, we did a tissue biopsy. We did the next generation sequencing for this retroperitoneal fibrosis tissue, and it detected he had a BRAF mutation, and then he was started on Zolbraf inhibitor in April. He really didn't tolerate it very much, some insomnia, lack of appetite. Not only that, he developed acute kidney injury, which is rare. Not only acute kidney injury, like the kidney function really went bad from his creatinine went from 0.6 to 2, and he developed severe proteinuria as well, so protein leak from the urine. So I had to stop the medication almost basically a month later, so from April to May. And then I started him on MEK inhibitor, which was uh, uh, on June 2nd. And then he had another side effect from that medication. You know that the Cotellic is 3 tablets. Some patients, the GI symptoms is really terrible, diarrhea. I have patients who develop diarrhea. You have to reduce the dose. He also had some contracture in the skin, tight skin, and he couldn't make a fist with his hand. So I reduced the dose from 60 milligram to 40, which really tolerated very well. So the point about this is that you have to really work with your patient and really don't push medications because we want to make the patient feel better, not worse. So you get to the dose where the patient can tolerate, and if it's working, that's great. Uh, so I repeated the scan, and this is just a couple of months ago, 3 months ago, or 4. And you can see that I'm just highlighting that if everything, you can see that really decrease on the metabolic activity, the resolution of the right. He had the cardiac involvement, so the atrial precordial avidity, the size and the metabolic activity in the lymph node. He had mediastinal lymph node involvement. I mean, it's remarkable. The sclerotic changes in his lower extremity. Also, the metabolic activity decreased, and the hepatic hypodensity, so the liver was involved, also got better. And obviously, you don't have to listen to the cardiologist. You can see that I'm going to go back to, because I showed you the lung before. This is the lung, the right lung, and this is the left lung. And you can see that the left lung here, this amount of, it's basically fluid. This is effusion in the left lung because of the Erdheim-Chester. And if you look at this lung in the next, you can see this is left lung, and really it's much better here. You can see that the fluid is really gone from this side, and this is we're talking about less than 6 months of treatment. So the management, what happened if the patient developed kidney failure? So we know that the ECD is really slow progressive. So we don't expect patients to develop in this stage, but it happens. So patients who develop to kidney failure, we can pursue dialysis, which has been successful in ECD patients. Not only that, we can do transplant as well in ECD patients. And again, the problem is that ECD relapse around the kidney graft, so it's not really safer. And I'm going to show you that this is also Harouche from France, who described those 7 patients who had kidney transplant with Erdheim-Chester. And I'm just going to show you that this patient was actually diagnosed with Erdheim-Chester after his death. So this was a post-mortem Erdheim-Chester diagnosis. So here, if you look at the markers here, so this bracket, black one is called death. So you can see here, death, this is after he died, it was discovered that this patient had Erdheim-Chester. And the blue is the kidney transplant. So this patient had a kidney transplant for about 3 years, and then he had been on dialysis. The pink is dialysis. So he had dialysis before transplant, dialysis after the kidney failed, but then he died. But the point here, you can see that the majority of patients here, 1, 2, 3, 4. So 4 of the 7 eventually passed. But this is the bad news. But the good news is that really after transplant, you can see that almost those patients survived with a kidney transplant for 8 years without a problem. And here, the red line here means that there is a recurrence of the disease. So you have patients who had obviously recurrence of the Erdheim-Chester in the transplanted kidney. And if you look here, this is the kidney on the CT, and this is the Erdheim-Chester. And the new kidney, which is in the pelvic area, you put it here. You don't take the other kidney out. You have the new kidney, and you can see that it started to develop this perirenal involvement of Erdheim-Chester as well. So transplant doesn't prevent. As I said, the kidney is a magnet for histiocytes, and if you have the disease, it's going to happen. But again, this is a slow disease, so transplant shouldn't be prevented or avoided in patients who develop end-stage kidney disease, although it's rare. So what is the takeaway messages for all of you? That 60 to 70% of patients with Erdheim-Chester will have kidney involvement. We wish, and I hope, more awareness of the disease, because really most of the problems happen because the patients are either misdiagnosed or not diagnosed, like my patients who was not diagnosed until I saw him in 2025, but he had the disease even in 2016, and I don't know how long before 2016 he had the disease as well. Uh, I think targeted therapy transformed the outcome in these patients, and I think I'm really happy to be part of the ECD community and really deal with Kathy and Belinda. And I think partnership with the patients and family is really a great uh, 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 thing to do with especially with rare disease, because those patients don't want to feel to be left alone. They need really support from all of us, physician and families. And I'm gonna stop here, and I hope I didn't bore you with a lot of things that you heard before. Thank you.